Pain on the side of the hip, or what we call lateral hip pain, can affect your sleep. It can affect your activity. And getting the right diagnosis is important to get the right treatment. So in today's video, I'm going to talk about one of the most common causes of lateral hip pain. Well, hello and welcome back to my channel. I'm Adam Rosen, and if you can, please take a moment and click the thumbs up button and subscribe to the channel so when videos like this come out, you are notified, and it helps people like you that are searching for information like this find this channel. In today's video, I'm going to talk to you about the lateral aspect of the hip. Now, most people, patients, and even a lot of primary care doctors and emergency room doctors basically call all lateral hip pain hip bursitis or trochanteric bursitis. But the side of the hip has a ton of anatomic structures, and it's not always trochanteric bursitis. One of the most common things that I see in the office, and I mean literally 2 or 3 times every single day, is what we call gluteal tendinopathy. It's tendinitis or partial tearing or tendinosis of 2 tendons of the hip called the gluteus medius and the gluteus minimus. And sometimes this has been referred to as a rotator cuff tear of the hip. And it can be hard to diagnose for some people, so you have to know the anatomy. There's been a catch-all phrase for what's been called lateral hip pain syndrome, or some people call it greater trochanteric pain syndrome. And it basically encompasses all of those structures. So you have the trochanteric bursa, you have the iliotibial band, you have these 2 gluteal tendons, and even where the piriformis inserts, all of those structures can cause pain. And in a lot of individuals, there's not only one diagnosis. Sometimes there's more than one. Now, it more commonly affects women more than men. Anatomically, women's pelvises are wider. This allows for passage of a baby, and because of that, it puts a little bit more stress and strain on these tendons, and it's more commonly seen between the ages of 40 and 60. Okay, so what are the symptoms? Patients typically come in with complaints of pain. They'll say, I have pain on the side of my hip. A lot of patients, if they're side sleepers, will say that they have difficulty sleeping on that side, even on the other side, because it pulls on the top hip if that's the hip that's involved. A lot of times they'll push and poke and find that it's tender on palpation. They'll note that there's a weakness. They might notice a limp, and that usually is a sign that there's more significant muscle damage. What can be perplexing for a lot of patients, though, is they'll say, if I walk a lot, when I start walking, I have pain, but the more I walk, it actually gets better, and they might have pain later that night. So sometimes it can be confusing for patients. So how do we diagnose this? Now, like anything, the first thing that we do is take a good history, asking patients, where they hurt, why they hurt, how long they've been hurting, was there a particular injury, change in activity. And the most important thing is an evaluation, what's called a physical exam. So we're going to poke and prod and push. And as an orthopedic surgeon, we're not just pushing on the lateral side of the hip. We're actually feeling particular spots where there's structure. So we're feeling where the trochanteric bursa is, where the iliotibial band runs over the side of the hip called the greater trochanter, where these 2 tendons, the gluteus medius and minimus, insert. And a lot of times, patients will describe kind of a diffuse pain, and as I'm poking around and I get to where these tendons attach, they're like, ouch, oh, that's the spot. That's the spot that hurts them. It's right where the tendons actually insert to the bone. Now, other things that we can do, you always want to watch someone walk, and some people have a particular gait, what we call Trendelenburg gait. So if your right hip is involved and those tendons are injured, damaged, or torn, as you step on that right leg, your left hip will drop closer to the floor. The other thing that we sometimes see is just pain with single leg stance. So I'll have patients stand on one leg, and usually just standing on one leg causes pain on the side of their hip if that's the side that has the injured tendon. Now, there's other things that we will do. So tests, x-rays are always helpful. Why? If you're a runner, we want to rule out things like a stress fracture. If you have arthritis, that can be a cause of pain. Also, a lot of times in people that have chronic symptoms, we'll actually see calcium deposits that develop at the tip of the trochanter, tip of that side bone on the hip, where those tendons insert. And that indicates to us that this has been going on for quite some time. Now, occasionally, additional imaging is needed. So if there's a question about the diagnosis, we might order an ultrasound or an MRI, which simply confirms the diagnosis. The hard part there is you don't want to start there because a lot of people have these tendon tears as a normal process of aging and don't have any pain. So if they don't have pain, there's nothing that we really do as far as treatment because they're not hurting. And then we get to treatment. Okay, so how do we treat this? And what I just explained to my patients is that this can be a very frustrating diagnosis because the treatment is not linear. A lot of times there's a lot of back and forth. The first thing that we always want to do is modify activity. So if someone's running or doing heavy squats or lunges, things that can aggravate the hip, we want to stop those for a period of time and let the tendon rest. The next thing is important is if someone is overweight. Every step, you're putting a lot more force on those tendons. So if weight loss is indicated, that's something that can help this problem. The next thing is reducing inflammation. This is an inflammatory process. So simple things like ice can help reduce pain. I sometimes even have patients do the idea of contrast, so ice and heat alternating. And then a course of an anti-inflammatory. So whether or not this is a topical anti-inflammatory like diclofenac or an oral anti-inflammatory, something over the counter like ibuprofen or naproxen, or occasionally I'll prescribe a prescription anti-inflammatory. A course of anti-inflammatory usually helps the symptoms. Then the next thing is we need to strengthen the tendon. So if you had a rotator cuff tear, the first thing that we would do is strengthen the tendon. And the same thing happens in a rotator cuff tear in the hip. We want to strengthen the gluteus medius and gluteus minimus muscles. And I have patients start with 2 basic exercises. So they start with this abduction exercise and a clamshell exercise. Now, with both of these exercises, I have patients start very slowly. 10 repetitions every other day for a week. In the second week, 20 repetitions. And the third week, 30. So if they're doing this Monday, Wednesday, Friday, when they get up to the 5th or 6th week, they're doing 60 repetitions Monday, Wednesday, Friday. Now they can break that into 2 sets of 30 or 3 sets of 20. The problem is that if you go home and you're an overachiever and you do 60, I guarantee you're going to be in more pain tomorrow and you're not going to want to do the exercises. So we're starting out very slowly. Now, if somebody gets to the point where 60 is easy, they might do more, or they might use bands, or they might add a little ankle weight, things that can increase the strength of the tendon once you've been able to do it with just body weight alone and gravity. Now, if somebody has pain, we've done anti-inflammatories tonight, and they even tried these exercises, and the pain is getting worse, not better. We really have to kind of cut back on all activity. So cutting back on the walking exercises and any other exercise classes that you're taking to let the tendon rest, and then using a cane or a hiking pole. And when you use this assisted device, it is in the opposite hand. So if your right hip is hurting, you would put the cane or the hiking pole in your left hand. And what a lot of patients do when I bring this up first is they kind of bug out and, they're not really happy. But when I have them just take 3 or 4 steps with a cane in the office and magically the pain is gone, they become believers. And what I typically tell people as far as how long you need to use this is I say, use it until you don't have pain, and then for 2 more weeks. And then don't start the exercises. I have patients then get rid of the cane or the hiking pole and make sure for the next 2 weeks that they don't have any pain. And then start with these abduction and clamshell exercises again. Now, for patients that progress with the home exercises and they want to take it another step, they might go to physical therapy, and I would write a prescription at that point. I typically don't start with therapy in the beginning because you can do these 2 exercises on your own, and my experience has been when a therapist has you for an hour and starts you doing a lot of exercises right away, it typically causes more pain early on, and therapy essentially is a failure. So therapy is great once you build up to it, but initially you can do a home exercise program. Injection. So is there a role for cortisone? So cortisone can be an effective treatment in patients with trochanteric bursitis that does not go away with things like stretching of the IT band and anti-inflammatories and change in activity. But we need to make sure that we're injecting the cortisone in that trochanteric bursal area. If you inject cortisone into these tendons, it can weaken the tendon, which can then lead to a rupture, which becomes a big problem. Now, there is an injection that in some studies has shown to be helpful, and that's the injection of PRP, or what's called platelet-rich plasma, and this can induce a healing response. But more studies will need to be done to kind of give a really good number to say what % of people get better. Now, is there a role for surgery? In some patients that have failed everything that I've just told you about, there may be a role for surgery, especially if they have significant tearing. Some doctors do this arthroscopically, where they go in with a small camera and debride the area and they can repair it. Some doctors do it open. Now, what if you have hip arthritis? So if you have hip arthritis, and again, a lot of people have these tears and don't know about it because they're not painful. When we do hip replacement, commonly we see these tears if you do a posterior approach. If you're doing an anterior approach, you can't see this. So if somebody has significant hip arthritis and you also have known gluteal tendon tearing that's painful and problematic, sometimes the surgeon will talk to you about the specific approach to make sure that they can address not only the arthritis, but also the tendon issue as well. So that's hip lateral pain, or what we call the rotator cuff tear of the hip, specifically gluteus medius and minimus tendinosis, or partial tearing of the tendon in a nutshell. I really hope that you found this information helpful, because if you're here for the hip, I've hopefully answered most of your questions. If you're watching the channel for the knee things, I do even see patients with this problem have knee pain, because when those hip muscles are weak, the leg can sometimes rotate awkwardly when you walk. It can throw off your gait. You kind of vault through the knee. So there's a lot of people that will present with knee pain without significant knee arthritis. And on exam, we actually find that they have these tendon tears. And simply by addressing the tendon tear and going through a strengthening program, their knee pain resolves. So thanks again for watching. I'm Adam Rosen, and until next time, stay safe.